All right, at this point, I think we'll get things underway. So welcome again, everyone. Thank you for joining our webinar today on patient preferences for antithrombotic treatments for an acute and chronic myocardial infarction. For those of you who I don't know, my name is Cathy Pinto, and I'm with Merck Sharp and Dohme, or MSD. And I'm going to be presenting today with my colleague, Tommi Tervonen from Evadera. And the case study that Tommi and I are presenting was sponsored by Merck Sharp and Dohme and conducted in collaboration with IMI Prefer. I would like to note that the opinions and perspectives shared by Tommi and I are our own, and we're not speaking on behalf of either MSD or IMI Prefer. What we plan to do today is to go through the material for the presentation. I would ask that you hold your questions until the end, but if you do have questions, feel free to post those in the chat room, and then we'll get to those as soon as we can. So before I begin, just a few words on IMI Prefer. So IMI Prefer is a large EU public-private partnership with many different members, including MSD, which you see here, which is Merck Sharp and Dohme. And Prefer is intended to look at how and when to incorporate patient preference information into medical decision-making processes. The primary deliverable for Prefer was to establish recommendations to support guidelines by industry, regulatory authorities, and HTA bodies. And the final recommendations should be available later this year after Prefer closeout in, I believe, May of 2022. I'd also like to highlight that in 2021, Prefer received a positive opinion on an EMA qualification procedure for preference research framework, and also points to consider for method selection. And I've included the link here below, which I believe Carl is going to post in the chat room for you. And I encourage those who haven't taken a look at the EMA qualification procedure documents, including the dossier that we submitted, because it's really a great resource for people who are interested in conducting preference research and submitting those data to regulators or HTA or payer organizations. Next, just want to level set the conversation and discuss what we mean by patient preferences. So the definition shown here on the left is one that is used currently by the FDA, by IMI Prefer, and other key stakeholders. But at a very basic level, preferences are what really matters to patients regarding their treatment, how much those features or attributes matter, and then what trade-offs are patients willing to make. So for example, is a patient willing to tolerate a certain degree of risk for an adverse event if they're receiving a certain benefit from treatment? Now, this next slide outlines the main content for today's presentation. I'm going to first start with some background on the therapeutic context, talk a little bit about the study design and results, then share with you some potential applications of preference data for decision-making. At this point, then, I think you'll be tired of listening to me. I'm going to turn it over to Tommi at that point, and he is going to present on a quantitative benefit risk assessment that we conducted using the preference data results from our study in combination with clinical trial and other real-world data. And then we'll open things up for questions. So first, a little bit about the therapeutic context. So the treatment of interest here are antithrombotic treatments, which are commonly referred to as blood thinners. And there's many indications for blood thinners. The one that we focused on here was the treatment of a myocardial infarction, or commonly referred to as a heart attack. And a heart attack occurs when blood vessels, mainly the coronary arteries, are blocked, and the heart is deprived of oxygen, leading to subsequent tissue death or necrosis. The blockage is caused by a buildup of fats and other substances in the arterial wall, as depicted on the right here in this illustration. And antithrombotic drugs are used to prevent perhaps a new heart attack from occurring, a stroke due to blockage of blood flow, not to the heart, but to the brain, and then death due to severe blockage of the arteries. However, because these treatments thin your blood, they can also cause bleeding, which sometimes is severe in nature. As antithrombotic drugs are developed and approved for administration during different stages of a myocardial infarction, including the acute stage, or soon after hospitalization for symptoms, and the chronic stage, which is after stabilization of symptoms and the patient is subsequently discharged from the hospital, our main research question was, do preferences for these different stages of disease differ? And this would help with decision-making processes as it relates to the development of each each drug for the different indication. We were also quite interested in preference heterogeneity among patients. This is important to understand. Is there a meaningful subset of patients for which there is a favorable benefit to risk balance? And this information could be used perhaps for an indication statement for the drug, or it could otherwise inform the label. Now, a little bit about our study design. So we started with a literature review, which then led to attribute selection. So these are the features of the treatment that we were interested in evaluating. And then we developed our initial survey, which we brought into a qualitative study with 10 patients. And during the qualitative study, we conducted interviews. We got feedback from the patients on whether the survey was comprehensible, were all the important treatment attributes from their perspective included, and other information that then helped us incorporate that feedback, which is very important to us, into the survey design. We then brought that survey forward to our main study, or a quantitative study, and we conducted the quantitative study in a stepwise approach, where we initially conducted a small quantitative pilot of 40 patients. We then evaluated those results, incorporated that feedback into the design, and then conducted the main survey. In terms of the design features, the main preference elicitation method that we used was a discrete choice experiment, which is a common method which allows trade-offs of patient preferences or treatment attributes, I should say. And this information was very important for us for the benefit risk assessment that we were planning to do. We recruited our patients from two sources. So the acute MI patients were recruited through NHS clinical sites in the UK, and then the chronic patients were recruited through an online panel in the UK. The treatment attributes and levels are shown here, referring back to the therapeutic context. The features that were important were reducing the risk of cardiovascular death, non-fatal MI, non-fatal stroke, and then severe bleeding, the most severe form of which is intracranial hemorrhage or bleeding in the skull. And this is referred to, the acronym used as ICH, and then also other forms of severe bleeding. Additionally, in the preference study, we also evaluated health literacy and numeracy. The next slide here shows a sample of our DCE questions. So those of you who may not be familiar with a DCE design, the patient is presented with this profile for treatment A here, and then treatment B. And basically for treatment A, for all the attributes that I had mentioned, levels are presented for treatment A, and then similarly for treatment B. And then overall, the patient is asked, based on this profile for each of these treatments, which one should you choose? And then these profiles are presented to the patients over and over again, and the frequency of the profile presentation is driven by the experimental design. In terms of the study results, the results show that there was no overall significant difference between preferences for patients in their acute and chronic phase of disease. So this is showing preferences for patients who had acute disease and these that were in more chronic phases of their disease. We did not detect significant scale effect between the two groups, and preference heterogeneity was assessed with an interacted multinomial logit, and we didn't see a significant effect there. As a result, this allowed us to then combine the data across both patient samples for further analysis. And we conducted, for example, an assessment of maximum acceptable risk, so trade-offs that patients were willing to make to reduce the risk of CV death, and then also assessment of preference heterogeneity. This first slide shows the study results for maximum acceptable risk. So again, this was based on a pooled sample of patients. And what we saw here is that the patients were most highly averse to bleeding risk, most notably the risk of non-fatal ICH, showing the maximum acceptable risk for reduction in CV death. And on average, patients were willing, for example, to accept a 1.4% increase in the risk of death to reduce the risk of non-fatal ICH by 1%. We also looked at preference heterogeneity, as I had mentioned, and we found heterogeneity based on age, bleeding risk factors, and risk of future ischemic events. So what this is showing is the odds of a 1% decrease in risk of CV death, non-fatal MI, non-fatal stroke, non-fatal intracranial hemorrhage, and other forms of non-fatal severe bleeding. And for example, we saw here that patients who were greater than 60 5 years of age valued a decrease in the risk of non-fatal MI more than those less than 65. And we also saw heterogeneity here as shown or highlighted for patients who had more than one bleeding risk factor, and then also those that had a greater risk of future ischemic events. This is the Tommi score shown here, which is a composite score that indicates the risk of future ischemic events. Now, at this point, I'm going to discuss some potential applications of preference data for decision-making. It's over time, regulatory authorities are recognizing the value of patient preference information for medical product decision-making. And most recently, there was this 2021 FDA guidance that was issued, and it explicitly points out that patient preference may be useful at various stages of development. And they highlight here some ways that it could be used is to inform the therapeutic context, to identify endpoints, and to inform a more formal benefit risk assessment. Additionally, there are many different ways to apply preference data. And again, referring back to that EMA qualification dossier by Prefer, Prefer has a really nice description of how preference data can be applied in decision-making. And the ways that they point out is that it can be applied in isolation. So for example, to identify what treatment attributes are most important, that could be used for endpoint definition. It can also be used in parallel with clinical or other data. And I have 2 examples here to illustrate this. And then it can also be mathematically combined with clinical or other data. And this is the way in which Tommi is going to discuss presentation with our quantitative benefit risk assessment. The first example here is how preference data can be used in data visualization. So this was an example of a forest plot that was presented by Johnson & Johnson several years ago during an advisory board meeting. And what this shows is that for this treatment, all the clinical outcomes that were important, and it orders those in terms of what patients felt were most severe or least severe. So the outcomes that favored the study drug are those that are shown here, and those that favored the comparator are shown here. And what you see is when you look at this really nice presentation and a quick visualization of the fact that those outcomes for which there was treatment benefit, those were the ones that patients valued most. Another example here is a hypothetical one, and this draws back to the preference study that we conducted. So say a company was developing 2 different antiplatelet drugs. One, again, was for administration soon after hospitalization, so during that acute period. And then another drug, drug B, was being developed for administration after hospital discharge. So if it was a scenario where it was a very resource-constrained environment within the drug company, there may be a need to choose among these 2 drugs as to which drug is being brought forward for development. So what this is showing here is you could have an example where the clinical profile for drug A and drug B shows that the risk of a reduction in the risk of CV death is similar for both of these drugs. However, the increased risk of severe bleeding is different. And it may be a scenario where drug A has less a risk of severe bleeding than drug B. And such information can be used to then have a discussion about which drug it is that you're bringing through for development. So I think what the important take-home message here is that with benefit risk assessments, it's not only important to focus, of course, on the clinical outcomes for a given treatment, but also what kind of value judgments are applied then to look at the overall benefit risk balance for a given drug. And of course, it's important to take into consideration the value judgments of patients, as those are the ones that are ultimately taking the drugs that we develop. So at this point, I'm going to turn things over to Tommi, and he's going to present the quantitative benefit risk assessment that we conducted. Tommi?
Thank you, Cathy, and thank you everybody for attending. So I will be talking about the use of the preference data in a quantitative and a very certain type of quantitative benefit risk assessment. We call it personalized patient-centered benefit risk assessment. And I hope at the end of this presentation, you'll have a bit of an idea of what this terminology means. So historically, the benefit risk assessments, the quantitative ones, have focused on the average patient. So if you look at the examples that Cathy was presenting on the previous slides, they were essentially looking at the mean effect of the treatment on the patients, as well as the average rate of adverse events in the follow-up, for example, in the pivotal trial. Now, such aggregate assessments may not be always useful to determining which treatment is suitable for an individual patient, because the individual patients might have different, for example, existing comorbidities that make them more predisposed to the risk factors that are elevated by the treatment. And then the individuals are also very likely to be differing in their preferences. So there's differences on these two sides of the coin. One is on the clinical outcomes, and another one is on the patient preferences. And in order to demonstrate the value of doing analysis which takes such differentiation between individual patients into account, we applied the patient preference data from the study that Cathy was describing to weight the expected dual antiplatelet treatment outcomes for individual patients in the real world. And this is fairly complicated analysis, but I'm hoping to give you a bit of an overview of what all happened in here. So first of all, we had three data sources. The first data source was real-world data from CPRD that we'll describe a bit more in the next slide, that we used to estimate per patient baseline risk of relevant treatment outcomes. So these outcomes that were included in the patient preference study described earlier. Then afterwards, we used clinical trial results to estimate the attributable treatment effect on these individual outcomes. So for example, in terms of an antiplatelet drug, we know based on a clinical trial that it increases the risk of bleeding by a certain amount on average on patients, but it also comes with the treatment benefit of decreasing the risk of further ischemic events by a certain amount. So those clinical trial results were directly applied then to these individual baseline risks of the events. And lastly, we then took patient preference data to weight these attributable treatment effects to come up with treatment's net clinical benefit. And when you use the patient preference data in such way, you come up with what we would call weighted or preference weighted net clinical benefit. And we also wanted to assess the difference between doing such preference weighting and of just doing simple or traditional net clinical benefit estimation where each of the outcome would be weighted equally. And the terminology here might be a bit of different to what many of you or some of you are used to, but this essentially estimation of weighted net clinical benefit using an antilinear model is similar to standard multi-criteria decision analysis, which is already used by regulators for benefit risk assessment. And for a nice example, I recommend reading Leela Lackey's recent study that has been published in Circulation last year. Next slide, please. So in this study, for the quantitative benefit risk assessment part, we took data from the UK CPRD that was linked then to the hospital episode statistics and mortality data from the Office of National Statistics. And then with those data sources and including patients who were adults and had experienced at least MI at least 14 days before the starting of the follow-up period, we ended up with what we call here CPRD risk equation population on the graph on the right, 31,941 patients. And this data set was then used for estimating these risk equations, but we also wanted to apply preference data into this population. And one of the factors that we knew from the patient preference study that affected patient preferences, so caused preference heterogeneity, was the presence of bleeding risk factors, as Cathy presented a few slides ago. So there was not complete data for all of these patients. So in the quantitative benefit risk assessment, we then only included patients for which we could establish whether they have no bleeding risk factors or whether they had at least one bleeding risk factor. So then the further quantitative benefit risk assessment was conducted with 22,125 patients. So we had these risk equations estimated with a slightly larger population, and then they were applied to the 22,125 patients. So we then had for each of these patients their baseline risk of all the relevant outcomes, for example, non-ischemic stroke, non-fatal ischemic stroke, non-fatal MI. Then we applied the clinical trial hazard ratios to estimate the attributable treatment effect on each of these outcomes and added those together to get the unweighted net clinical benefit, and then apply the patient preference weighting to get the weighted net clinical benefit. Next slide. And I think the main result is here on the title. Net clinical benefit was affected by the patient preference. So on the right-hand side, you have this figure where we have for different subgroupings, the results from the equal weighted analysis, where all of the outcomes were equally weighted, and as well as from the preference weighted analysis, where the outcomes were weighted with the patient preferences. So the blue dots are from the preference weighted analysis, and the red dots are from the equal weighted analysis. So if you look at the full cohort, you see that on average, the weighted net clinical benefit was lower in the preference weighted analysis than it was in the equal weighted analysis. And how to interpret this number? So the 0.057, it means that there was a reduction of 5.7% in composite risk of an outcome, of a composite outcome that includes all the outcomes events that we were focusing on this analysis in patients that were treated for 3 years with dual antiplatelet therapy. So obviously the therapy increases their risk for somewhat of their bleeding risk, but it also significantly decreased for many patients their risk of further ischemic events. And if you look at the absolute of these numbers, they tended to be always lower in the preference weighted analysis, and this is explained by the patient preferences presented earlier by Cathy. And so the patients were fairly averse to the bleeding risk caused by the dual antiplatelet therapy, and therefore, when you take the preference weighting into account, the weighted net clinical benefit is lower than it would have the unweighted net clinical benefit when the preferences are not taken into account. However, the direction of the effect was unchanged in all analyses. The overall net clinical benefit, weighted or unweighted, was always positive, expected for this treatment. But the preference heterogeneity affected the ordering of the net clinical benefit in subgroups. So if you look at this bottom left box in the figure, these are patients who were at the older end of the spectrum, so about 65 years old, and had high risk of further ischemic events according to the Tommi index. So when you look at the blue dots, that's a preference weighted analysis, the patients who had no bleeding risk factors had a higher net clinical benefit than those patients that had at least one bleeding risk factor. Whereas when you look at the red dots, which are from the equal weighted analysis, the patients with at least one bleeding risk factor had a higher expected net clinical benefit than patients with no bleeding risk factors. So the incorporation of patient preferences in this analysis could potentially have downstream implications for decisions that would be taken based on the quantitative benefit risk assessment. Next slide. Overall, the distributions in our study population, empirical distributions were similarly shaped in these two analyses, so between the equal and preference weighted analysis. The equal weighted analysis, the distribution was essentially shifted a bit to the right and had a slightly larger variance. And the reason why we were not observing such high differences in this analysis that could be observed in other analyses was that the ischemic and bleeding outcomes were highly correlated. So rho was 0.89. And it is kind of natural when you think about these patients a bit more in a clinical setting. So the older patients and the more frail patients, those are the patients who are at a higher baseline risk of further ischemic events. Those are the patients who benefit more from this dual antiplatelet therapy. But those are also the patients that are at the highest risk of experiencing bleeding events. So essentially, the patients who have the highest benefits, they gain the highest risks, and the patients who are expected to gain lower benefit from the treatment are those also with lower risk of the side effects. So for that reason, this differential patient preference weighting did not have huge effect in the analysis, even though it had an effect that could affect any decisions taken or supported by the quantitative benefit risk assessment. Next slide. So overall, through this different phase of the study, we could conclude that we did not detect differences in patient preferences by the MI stage, although larger study could detect such differences, of course. I mean, when you increase the sample size to increasing towards infinity, you will always get statistically significant differences, but they would not be expected to be of magnitude relevant for benefit risk decisions. So let's say that we would conduct a study with double the size of that we had in here. you might detect preferences by MI stage, but the preference differences would be so small that they would have really little implication for any benefit risk decision that would be informed by such patient preferences. Then the MI patients are averse to potential bleeding side effects of antithrombotic antithrombotic agents, and their preferences were further affected by age, bleeding risk factors, and risk of further ischemic events. And last but not the least, the net clinical benefit of antiplatelet therapy was affected by patient preferences in our personalized patient-centered benefit risk assessment. Next slide. There are a bunch of papers that have come out from this research stream that if you're interested, I recommend going to have a look at them. First of all, the primary manuscript from the patient preference study is the first one on the list, the Pinto et al. That was published in the patient, currently still in the press, but accepted for publication last year. Then the net clinical benefit paper that I was talking about is currently in press, but available already online in the Journal of Clinical Epidemiology. And the non-preference weighted part of that analysis, the last paper on the list, the Pinto et al., was published in Pharmacoepidemiology and Drug Safety in 2019. And I believe all of these papers are open access, at least the one in the patient and in the JCE are open access, so available for everybody to freely read in the journal webpage. We also have this more methodological papers still under review in a journal, where we were assessing the differences between two preference instruments, discrete choice experiment and best for scaling case 1, that we included as a secondary preference instrument in the patient preference study. And we hope that that will be also available for everybody to read in the near future. Next slide. I'd like to acknowledge that, well, I'd probably like to acknowledge more people that are on this slide, but I think it's important to appreciate the contributions of some that have been integral in this research stream. So few people from Evidera, Thibaut Pravitz, that did a lot of the data analysis essentially in the especially in the quantitative benefit risk assessment, Ella and Ginny that used to be very involved in the patient preference study, as well as Johanna Heisen from the Merck side. We also had John Bridges, who's currently at the Ohio State University, that was advising on the design of the patient's preference study, especially at the earlier phases of the project. There's probably tens of other people, both from Evidera as well as from Merck, who've been interacting at some point in one of these components throughout the project. So too many to thank, too many to acknowledge, but it has been truly a team effort.